Yeah, good afternoon. So, on the behalf of CDR, we invite you all to the clinical grand round for today on the topic of oral potentially malignant disorders from conventional approaches to technical advances, jointly presented by Division of Oral Pathology and Microbiology with Division of Oral Medicine and Radiology, CDR. So, we'll be discussing about the clinical and histopath features of OPMDs, molecular techniques for biomarker detection for OPMDs, followed by OPMD datasets and AI models for OPMDs, MedTech solutions for OPMD screening and treatment for OPMDs. So, what are OPMDs basically? So, OPMDs basically constitute a heterogeneous group of lesions which have a potential to convert into malignancy. So, most of these produce clinically visible lesions, and OPMDs such as leukoplakia, erythroplakia have a malignant transformation rate ranging from 0.13 to 17.5%, and erythroplakia from 14 to 50%. PVL has a very high malignant transformation rate ranging from 40 to 100%, whereas oral submucous fibrosis can transform into malignancy in 2.3 to 13% of cases, and OLP can show a malignant transformation rate of 0.4 to 3.7%. So the first image on the left corner, upper left corner, is an OPMD, which can show this kind of histological features. You can see there is not much of dysplasia and you don't see any obvious invasion. Now this can transform into this malignancy with this kind of histopathological features where you can see invasion of the epithelial items. Now the current OPMD prevalence, Asia accounts for the highest number of OPMD cases. Leukoplakia can be homogeneous and non-homogeneous. So the total prevalence of oral leukoplakia in Asia is around 2.5%, which is highest in the globe. Within leukoplakia, homogeneous accounts for around 6 to 75% of cases, and non-homogeneous account for 25 to 40% of cases. Oral erythroplakia accounts for 0.04 to 0.2% of cases, and oral submucous fibrosis around 3%. But in India, because of the very high frequency of gutka chewing, it can go up to 6%. Oral lichen planus account for 0.5 to 1.5% of cases. Within India, the oral leukoplakia has a prevalence of 1 to 5%, oral erythroplakia 0.50 to 0.2, oral submucous fibrosis 1 to 3. Again, it is increasing because of the increased prevalence of the gutka chewing among the population, followed by OLP 0.5 to 1.5%. Now, our department stat shows that from 12,000 specimens, OPMDs account for 6% of the total cases. And within these 6%, the most of them are oral epithelial dysplasia, which is the histological counterparts of OPMDs such as leukoplakia and erythroplakia. 30% are varicose aplasia, 3% are oral submucous fibrosis, and 6% are lichen planus. So now I invite Dr. Deepika Mishra to share her experience with OPMDs for the last week.
Thank you, Dr. Baru. So just to take you through the journey for last 10 years, we started when I joined AIIMS in 2015. We saw that the maximum number of cases what we see in general OPD are OPMDs because of definitely the prevalent use of tobacco habits. So what we started was chairside diagnostic techniques like vital staining or cytopathology, which was easy to do with less of resources required. Followed by we were fortunate to start with histopathology and IHC services for better diagnostic purpose of OPMDs. Followed by certain other adjuncts like fluoroscopy, spectrometry, which could also be done, which these techniques or diagnostic adjuncts are also being used for the research purposes to aid in finding the right site for biopsy. So basically clinical decision support systems. Followed by we could start with the frozen section reporting, and then everything could be integrated into lab information system so that the clinicians can have the reports of their cases. And then we started looking into various biomarkers to various other techniques, like for example, we started with the direct immunofluorescence techniques for better diagnosis of vesicular lesions, or certain like OLP and differentiating it from discoid leukocytomatosis and diseases like that. We could also start India's first computational pathology lab, which was basically using more of a slide scan images, which could be used for developing AI models, as we'll hear more about it in our presentation. And then we could start with certain telepathology services. We can understand India having such a diverse different departments. So how we can support other departments in providing them the second opinion for the cases. And then we looked into standardization of all the diagnostic services. So we got it NABL accredited. And recently now we are looking into oral microbiolosis, how it could be used to predict the progression of oral potentially malignant disorders. And in this entire journey, we were also we looked into medtech collaboration, so that whatever diagnostic services we are trying to look into, how they can benefit the public health, so as to look into the disparity of lack of doctors in the rural population, so how we can build up those tools so that those cases could be detected early. So in short, the entire thought process of the journey was mainly focusing how we can catch oral potentially malignant disorders early so that we can prevent them from turning into cancer. So with that, I would like to call upon Dr. Akshaya, Senior Resident, to just tell us about the case presentation.
Good evening, everyone. I'll take you through the clinical features and histopathological features of oral potentially malignant disorders. So as we all know, there are associated or risk factors which is associated with OPMDs like tobacco, areca nut, alcohol, then physical irritants like sharp teeth, certain viruses like human papilloma viruses, fungal infections like oral candidiasis are associated risk factors with oral potentially malignant disorders. Now, these are the oral potentially malignant disorders that I'll be talking about. That is leukoplakia, proliferative varicose leukoplakia, which is a form of leukoplakia, erythroplakia, oral submucous fibrosis, and oral lichen planus. Now, coming to leukoplakia, here we can see the two images. Leukoplakia, the major culprit is tobacco. So here we can see the first image is a homogeneous white patch which is present on the buccal mucosa. That is a form of leukoplakia, and non-homogeneous on the other side. We can see there is a nodular growth, nodular flat growth, which is interspersed with red areas. That is non-homogeneous form of leukoplakia. Next is erythroplakia. So erythroplakia presents as a velvety red patch, and problem with erythroplakia is that when we take biopsy from the specimen, at times there will be carcinoma in situ histopathologically or early invasive carcinoma. So this is what we see: indistinct basement membrane in the histopathological image and certain suspicious foci of invasion. Next, we'll talk about proliferative varicose leukoplakia, which is again a form of leukoplakia. So this is an extensive form of leukoplakia. The characteristic feature about proliferative varicose leukoplakia is that multi-site involvement, and on histopathology there can be a spectrum. That is, the first, it is seen as corrugated hyperkeratotic lesion progressing to bulky epithelial proliferation. So in the first image, we can see there is voluminous growth of the epithelium, there is hyperkeratosis, and there is lichenoid-like reaction which is present in the first image. Followed by what we can see, there is voluminous growth of the epithelium again, and there is bulbous pushing type of retrorages and with lichenoid reaction, that is bulky epithelial proliferation. Next, we'll be talking about oral submucous fibrosis. So the major culprit here or etiologic factor is areca nut. So in oral submucous fibrosis, we see that there is reduced mouth opening, trismus, and difficulty in swallowing. So, and rarer complications also can be hearing loss. So what you see in histopathology is that there is replacement of the underlying muscle with the fibers, and there can be dysplasia in the surface epithelium. Next, we'll talk about oral lichen planus. These are very classic. This is a classic oral potentially malignant disorder where you can see AIIMS striae on the buccal mucosa, but there is other forms of clinical forms of lichen planus as well, where you can see annular plaque erosive lichen. So in histopathology, what we see is atrophic epithelium. Sometimes the epithelium can show sawtooth-like reticulous and basal cell degeneration and an inflammatory band of reaction. Next is these OPMDs like oral lichen planus and oral submucous fibrosis are very classical. But when we talk about oral leukoplakia or proliferative verrucous leukoplakia, they present as dysplasia. So understanding dysplasia is also important. Leukoplakia is a clinical terminology and dysplasia is a histopathological terminology. So grading dysplasia, that we follow this two system for histopathological reports as well. That is 3-tier and binary system. So 3-tier, we are going to divide the histopathological grades as for OPMD as mild, moderate, and severe oral epithelial dysplasia. Whereas binary system is low risk and high risk. So there are WHO criteria for grading dysplasia, and there are certain architectural features that account for 16 features and cytological 12 features. So here in the images we can see few of the features. In the first image, you can see there is increased keratinization. Now, one must understand that keratinization will be seen in the superficial layer or the granular and spinous layer. But we can see that increased keratinization is seen in the spinous layer of the epithelium or the lower strata of the epithelium. Then there is reduced keratinocyte cohesion. We know that epithelium are adhered to each other by desmosomal junction. But this, we can see there is reduced cohesion in the keratinocyte. There is drop-shaped ridges as well. Next, in the lower image, we can see there is anisonucleosis, increased number of mitosis and clustering, basal cell clustering. Next, now let us take a hypothetical example here for grading an oral epithelial dysplasia. There is an anatomical structure at the interface of the epithelium and the lamina propria that is called as basement membrane. So when you start grading the dysplasia from lower 1/3 and the dysplasia is present in the lower 1/3, it is called as mild oral epithelial dysplasia. And when it involves the lower 2/3, it is called as moderate oral epithelial dysplasia. And when the full thickness of the epithelium is involved, it is called as severe oral epithelial dysplasia. And if there is a breach in the basement membrane, it is called as squamous cell carcinoma. So these are the images: the mild lower 1/3, moderate upper 2/3, and severe dysplasia full thickness. So this is the binary system that we follow with the 3-tier system, where we grade that or divide the OPMD into low risk and high risk histologically, where low risk is amenable for regular clinical surveillance and pharmacotherapy, and high risk for surgical excision. So this is what the report is, like one of our report, where in the impression we mentioned severe oral epithelial dysplasia, high risk. So understanding field effect is also important, because sometimes when the patient comes to the clinic, we see that there is squamous cell carcinoma which is arising in a setting of oral potentially malignant disorder. There will be a white patch and there will be multifocal involvement, multiple squamous cell carcinomas in the oral cavity. So that is because of the field effect. So this is the field what I'm talking about, the blue cells. There's a tumor which is set inside. And if the surgeon is taking the tumor out or excising the tumor out, there can be an instance that there are some tumors which are seeding inside, which culminates for local recurrences. And there can be expansion of this field which will lead to second field tumors. And there can be an independent event which is separated by a normal healthy mucosa, and that can lead to second primary tumors. So this is like multiple tumors in an OPMD background, where we can see there are multiple tumors in this clinical picture. So next I call Dr. Reva.
Good afternoon, everyone. So after having an overview of what OPMDs are, I would like to discuss the molecular techniques, the conventional as well as the advanced molecular techniques which we can employ for diagnosing OPMDs. So conventionally, the techniques employed to diagnose OPMD, they involve clinical examination followed by vital staining, obtaining the biopsy tissue, and then the gold standard method, that is the histopathological examination. Now, in the recent years, advanced techniques are being employed for the risk stratification of OPMDs as well as for monitoring the disease progression. So these basically employ saliva, which is a non-invasive diagnostic medium being used. The techniques used nowadays include proteomics, metabolomics, metagenomics, which are together called as multiomics technique, genomics, and transcriptomics. So these are the adjunctive techniques which are now in use for risk stratification and the monitoring disease progression in OPMD. These include the conventional brush cytology or the liquid-based cytology, tolerant blue staining, Lugol's iodine, then the chemiluminescence visualite approach, narrowband imaging, optical coherence tomography, and the more advanced techniques which are now emerging in the field of OPMD risk stratification include salivary biomarker analysis. So these analyze proteins, metabolites, DNA, RNA, molecular techniques like PCR, QRT-PCR, ELISA, liquid chromatography, mass spectrometry, NGS, and the most recent ones, they include the AI-based diagnostic tools. So now I'll be discussing and talking about few of the studies which have been completed and which are ongoing in the department, employing these techniques which we've already discussed. So this was a study which was done a few years back. So in this study, we had studied the use of Visualite, that is the chemiluminescence approach, along with the tolerant blue application. So Visualite is a type of optical instrument which uses the chemiluminescence technique. So in this, the hyperketotic areas or the cells which have high turnover, they actually reflect the light, and the normal component of the oral mucosa, they absorb the light and appear dark. So in this figure, we can see the case of OPMD, which is appearing as aceto-white because it has highly keratinized surface, and this helps in identification of the OPMD, which are then confirmed by the histopathological analysis. So in this study, we found that Visualite had a sensitivity of 90%, whereas specificity of only 50%. Next, an example of S100 being used as a biomarker in OPMD risk stratification. So here we can see there is a case, the first image is employing S100 in a case of normal oral mucosa, whereas the second image shows the OPMD, shows the S100 staining in a case of OPMD. So we noticed high membranous, cytoplasmic as well as nuclear staining for S100 in OPMD cases. Another ongoing study aims to analyze the tumor heterogeneity in case of OPMD and oral cancer. So here from the paraffin embedded tissues, different samples were taken from the different areas, and then the novel mutations were found through whole genome sequencing. And so the superficial region and the tumor invasive front, the novel mutation found in these areas were noted. One of the component of molecular techniques, the most important component is if you use saliva, is the method by which we are collecting the saliva. So in literature, there is no standardized protocol for saliva collection for proteomics and metagenomics. So out of all the methods, that is spitting, draining, then swab method, we validated and we found that the best method for proteomics and metabolomics, also for metagenomics, was the passive rule or the draining method. So we formulated the saliva collection protocol, which is now being used in the department for the studies pertaining to proteomics and metagenomics. Another ongoing study includes taking saliva, scrapes, and tissue samples from healthy controls, oral cancer, and oral leukoplakia. And these are then being analyzed for the oral microbiome in saliva by the 16-less metagenomic sequencing of the V3, V4 band, micro RNA analysis by the NOPA 6000 platform, and also the cytokines, namely IL-6, IL-8, TNF alpha, and they are being studied by ELISA technique. So what we found that employing the untargeted microRNA sequencing, these 5 microRNAs were found to be significantly altered in cases of OPMD, out of which microRNA 21 showed the greatest significance in cases of oral cancer and in case of OPMD and normal healthy controls. So this table shows the target gene and the pathway which are affected by these most commonly affected microRNAs. Then we studied the oral microbiome in case of OPMD, oral cancer, and the normal tissues, the normal saliva, and the overall diversity, that is the overall different phylum which are found in the oral microbiome. They were found to be decreased in OPMDs and oral cancer, but there was an increase in specific bacteria, that is the Fusobacterium, Porphyromonas, and Streptococcus. They were significantly increased in cases of oral leukoplakia. Also, the inflammatory markers were studied, and out of these, IL-6 and IL-8 showed the highest concentration, showed the highest alteration in leukoplakia and OSC as compared to the control group. Now, taking a step forward from ELISA, now we are studying the cytokines by the AIIMS, that is the liquid chromatography mass spectrometry technique, which is a more sensitive and specific technique as compared to ELISA. So this is the principle of the liquid chromatography mass spectrometry device, which is now being employed for validation of these cytokines in the saliva and the tissue samples. So through a systematic review, we found the IL-6, CIFRA21-1, CD44, and IL-8. These markers are commonly altered in cases of oral leukoplakia and other OPMDs. So these are being validated through this technique. Also, we are in progress of developing a point of care kit based on these biomarkers. So as a prototype, we have developed the lateral flow assay technique employing the IL-6, that is the interleukin-6 cytokine. So this involves taking saliva sample and then subjecting it to the LFA assay, wherein the antibody to the IL-6 is already present, and that is captured by a labeled nanoparticle or gold particle technique, which gives the colorimetric results. And that color change is then studied through a portable reader or a smartphone application, which converts that color intensity into the numerical data of the biomarker, and it helps in the misstratification of the disease by analyzing the values. So now I would like to request Dr. Anubhuti to please give us an insight of the use of AI in OPMDs and creation of data sets.
Thanks, Reva. Thank you for that work, that walkthrough, to that molecular analysis and all the technologically advanced stuff. So I'll be taking you through a different work of research that we have been doing in our department. So nowadays, the government of India plays a lot of push on developing AI-based real-world solutions for implementation in the field as well. So with the vision of developing, real-world implementation solutions and using for developing the screening devices as well as the implementation devices for the pathologists to use as well, we embarked on a mission to create image-based data sets. So this was a vision for creating the image-based data sets, and we were fortunate enough to start off with the project known as the MIDAS. The goal of the project was to develop gold standard data sets for development and comparisons of image analysis-based applications, primarily for all the OPMDs. So with regard to the creation of the image-based data sets, we were quite fortunate enough to develop all the SOPs and the guidelines which were in compliance with the WHO's goal for AI for general health. And apart from the creation of the data sets as well as the SOPs and the guidelines for the image capture, for the image assembly, for the development of the platform as well, we were able to develop quite an extensive infrastructure backbone in our department. The research team, they strived forward to create an entirely novel computational pathology lab, as mentioned by Dr. Deepika as well. So apart from the same, we were able to create a data anonymization and annotation facility, which hopefully will be open for the rest of the institute in the nearby future. We also have a setup for the servers at AIIMS, by which we are able to store the entire data set, and in future it will be open source. While some of it we have released it on the open source platforms, the entire data set will be open soon. So during the creation of the image-based data sets, we were able to create a lot of SOPs, the guidelines, then the manuals for the creation of the image-based data sets. So this comprised of the clinical images, gross images, radiological images, histopathological images, even the whole slide images. This venture of ours it worked in a hub and spoke model with 5 of our partners in a national program, in the National Task Force project. And currently we have more than 1 lakh data sets with us upon which the AI models are being made. So that being said, nowadays a lot of push is there on the development of the image-based AI models known as the multimodal AI in the medical diagnostics. It is said that the combination of the medical imaging data sets and along with the metadata, we will be able to create AI models that will help in developing improved medical diagnostics and predictions of the patient outcomes. So with that in mind, we also ventured into the development of the image-labeled AI models, and we have been fortunate enough to develop one of our first AI-based models based on the oral epithelial dysplasia. As exhibited before, oral epithelial dysplasia is one of the most common OPMDs, 78% in our department to note so far. So that was the reason for moving on with this cohort. So when we were developing the pre-trained AI models, we basically worked with the pre-trained AI models, and the first models that we worked were with the convoluted neural network models. We found that we actually attained a maximum accuracy of 90%. That was with ResNet 18, one of the most basic pre-validated AI models. Along with it, we also tested ResNet 34, ResNet 50, and EfficientNet B0. All of them the CNN model. All of them are the CNN models. So in an attempt to venture out into the explainable AI, that is how the AI reasons its predictability, we also did some of the predictions by the GradCam visualization. So the GradCam visualization actually showed us that most of the model's predictions were based on at the interface between the epithelium and the connective tissue, along with the interface between the epithelium and the white tissue surface. So we were also able to test some of the other vision models as well. However, the vision models did not show us that kind of an accuracy that was required for the integration into the national health programs. The vision transformer model showed us only an accuracy of 65%. So for now, we will be progressing with the ResNet 18 model for integration into the national health programs. Apart from that, we also did an extensive literature review of why we should be progressing with such kind of solutions. So we found that most of the publications that are out there on the open source are primarily based on the whole slide images. So the whole slide images are made from basically whole slide scanner, which is essentially a very expensive piece of equipment. It is not essentially present in all of the institutions in a low middle income country like ours. So our data set, our AI model was advantageous that we were able to make it on the microscopic images, which is essentially available in all of the academic institutions throughout the country. Apart from that, the AI models that are present on the Indian population are virtually non-existent. Actually, this is the lower publication is the only publication that is available for the oral epithelial dysplasia at this point of time. So another good news for the rest of the global researchers is that we have recently been able to publish a large amount of data set via our tech platform. And this is one of the first open source labeled Indian origin image data sets for OPMDs. And it is out there in the public use. So all of the global researchers are free to use it for development of their own AI models. So with regard to the same, now currently I've been talking about all the histopathological based AI models and the future medtech solutions that can be derived from it. So I would now like to call upon Dr. Bharat to discuss the medtech solutions that are already in place by use of the clinical images of the MIDAS platform. And these are some of the publications that were able to come out of this research.
Thank you, ma'am. And as we have seen, we have been evolved through a long journey. We have evolved a long journey from the inception of traditional methods of from diagnosis to the AI models. But what about its implementation? How about we are going to diagnose the patients who are not stepping into AIIMS? That has been our vision for implementation of medtech solutions for OPMDs. So basically, one of the biggest challenges in India for the reduction of OPMD is the ratio of the specialist to the patient. It is about 1 is to 2000. Whereas there are some untapped potential workers. There are the frontline healthcare workers such as ASHAs, ANMs. So in that way, you can see there are about 9.8 million ASHA workers are there who, when they are given a proper tool to diagnose these OPMDs, they will serve as a major resource for reduction. So we were able to develop some of the innovations using the AI powered tools as well as some of the optical power tools for detecting these OPMDs that can empower these frontline healthcare workers. So mainly we have mobile based tools, we have multimodal autofluorescence fluorescence based tools and optical imaging microscopic device, and also some of the tobacco cessation app we are going to develop it. So let's come to the first one, AI power open source tool, which is a mobile based one. This is a white light based imaging tool. So along with AIIMS, IIC and ARPAC Bangalore, we have developed an app called the Oregon app, where we are going to collect the patient's data digitally, metadata, that is demographic details, patient's habit histories. Along with that, we will also capture the image of the suspected sites. And we are giving training for about 13 sites to capture the images. And once these images are captured, this will go to the cloud platform. From there, it will reflect into the remote specialist platform, who will give the provisional diagnosis. And based upon that, it will classify into suspicious, non-suspicious with a high risk or low risk. So once again, these details will go from the remote specialist platform into the mobile phone app of the FHW worker who has captured the images, who will do the follow-up and refer this patient to the nearby hospitals for the treatment. So that is the outline of it. And we have also made some of the IEC materials to train these ASHA workers. And these materials are available in various languages and most of them are animated. So far we are able to touch 24,000 participants in the phase 1, and it has been happening throughout the India. I mean, we have been collaborated with 11 states and we are getting data from throughout India. And this is some of the data that we have arrived from our phase 1. And we can see that among that, most of them are non-homogeneous leukoplakia, and the next one is we have erythroplakia, varicose leukoplakia, and PDL, as well as oral cancer, that is oral cervical stomach carcinoma. So, with this information of phase 1, we stepped into screening using this tool for screening the patients from the Mahakumbh 2025. In collaboration with Netrakumbh, we were able to establish Arogya Mukkumbh, and we were able to use this device and screen the patients over there, participants over there. And this study, we were able to derive that the automated mapping model that is embedded into this app is performing much better than the remote specialist, because it has collectively about an image of around 2 lakhs has been there, and we have been trained with it, and therefore it is having a better accuracy, better sensitivity and specificity, whereas this is compared with the gold standard of the on-site expert. The next, we also wanted to employ some more, we have ventured into rural areas where the resources are even more limited, and therefore we have developed few strategies that includes our collaborations with the technological cohorts such as IIC and ARPA, and also institutional cohorts throughout India. There are 16 institutes among 11 states in India, and also village stations through the help of the NGOs such as Akshay Patra. And then we are next we are going to integrate into the district level national cancer screening programs, and we have already started these ones, and I will go through one by one. So far, among the 16 institutes, these are the 16 institutes that I have mentioned, we are able to get a data from about 5,719 participants. And among the village screening, it has been started in two districts from Uttar Pradesh and Uttarakhand. 35 villages have been screened and 8 slums among them. And this has been integrated into the district level of Sambal and Mathura from the Uttar Pradesh. And already the training for FHW workers has been carried out. So next devices, we have also another innovation, multimodal autofluorescence and fluorescence imaging spectroscopy, where we are going to have 3 types of modalities. One is autofluorescence, fluorescence and spectroscopy, and we are going to use this image, and AI is already embedded into that, and it will give us the results of the suspicious area. This device is mainly devised for the surgeons who can precisely evaluate which area they can take the biopsy for. And so this has been already tested in CDR AIIMS and AIIMS and NCI judge. Now we have came to the second prototype from the model version 1. We have came to the version 2, which can be handled, and therefore it can be used in the resource limited settings. The third one is a low-cost multimodal optical imaging microscopic device. And with this device, again we have autofluorescence, fluorescence, and there is another one spectrometric device. All this can be used for viewing this light. And the specialty is it also encompasses something called as phage imaging. In a nutshell, without staining also we can see the cells. That is what we are working on at present. And the last one that we are developing is the AI-enabled platform for tobacco cessation and patient support at AIIMS. So right now, in the India, we can know that Arica net shielding is one of the most important causes for the OPMDs. But so far, there has been no mobile applications that is having any specific cessation protocols for it. And therefore, we wanted to work on that. And also, our vernacular languages are not available in any of these already available applications. So we are in the move for developing the TAN. So as I said, there has been a lot of protocols and lot of innovations has been made for detecting these OPMDs, and these all has been done keeping the stakeholders in mind. Various stakeholders such as patient and the patient's family, ASHAs, doctors, as well as specialists. So at each stage, we have developed one of the innovations to have the cessation at the right and left point. For example, if there is even no lesion, they can have the education awareness to the TANF that is we are working on. And if the lesion is present and if the patient is having any type of tobacco habit, then it will help them for tobacco cessation. And if there is a lesion and the patient is not able to reach the PHCs or any AIIMS or anywhere, still this RIGR can be used for screening these patients. That's why we are working on the district level integration, which will be, we are hoping it will be going to be integrated into the NCD programs. And once it reaches there, once again, as it comes to the PHCs, again the doctors can take help of these integrated multimodal imaging spectroscopic devices, where it will guide them for performing the biopsy at the exact site. And after this, once again, this histopathology and multiomics integration also will be working as a POC kit, so that it can be detected at the earlier stage. This was our planning in having these various type of innovations to do the cessation and detection at earliest as possible. As important as it is to detect the OPMDs, it is also important for managing. And so for that, I would like to invite Dr. Utkarsh for briefing about us the management.
A very good evening to respected chief plan, respected faculty members, and my dear fellow residents. Today I'm here to tell about the management of various OPMDs. So first will be the tobacco cessation counseling. So there are 5 A's, which are ask, advise, assess, assist, and arrange. So we have to ask the patient whether he or she is using tobacco products or not. Then advise. We advise the patients not to take the tobacco products in a very firm, clear, and understandable language. Assess the patient if he or she is willing to quit the tobacco. Assist in the form of making a proper chart for tobacco usage and counseling, and various therapeutic agents to be given to the patients instead of using tobacco products. Arrange a follow-up visits. This can be personal and on phone calls as well. So WHO recommends varnicillin, NRT, which is nicotine replacement therapy, and bupropion as recommended first line of tobacco cessation counseling. Patient education about how to perform self-oral examination is very much important. Documentation of proper clinical photographs is also very important. Oral prophylaxis should be done. Management of the confounding factors, like if suspected oral candidiasis, proper antifungal therapy should be given to the patient to reduce the chances of carcinogenesis. Control of systemic conditions and medical conditions like diabetes mellitus, hypertension, and thyroid disorders should be done. Nutritional and supportive therapy, like antioxidants, vitamins, and various micronutrients should be prescribed to the patient. Proper diet therapy, fruits and vegetables should be prescribed, and lycopene-rich dietary foods, which are tobacco, which contains various antioxidants and anti-tumoral effects should be given to the patient. Diagnostic protocol, proper thorough clinical examination and physical examination of the entire oral cavity should be done. Biopsy and histopathology, which is the gold standard for the definitive diagnosis of various OPMDs and oral cancer, which includes incisional biopsy as well as excisional biopsy. Incisional biopsy is generally recommended and taken from the suspicious area. Excisional biopsy is considered only when small lesions are present, which are less than 1 centimeter in size. Adjunctive aids like autofluorescence, chemiluminescence, and vital staining by toluidine blue can be done. Coming to the proliferative verrucous leukoplakia, the aggressive form of oral leukoplakia. It's very challenging due to high risk factor and malignant transformation rate. So typically involves surgical excision of the whole lesion. Laser treatment can be done, electrocautery, cryotherapy, and photodynamic therapy can also be done. Medical and topical treatments like chemotherapeutic agents like bleomycin in topical as well as intralesional injections can also be given. Topical application of newly prescribed imiquimod 5% cream, which has anti-tumoral effects, can also be given. In attempt to prevent recurrence, topical use of retinoid, vitamin A, and antioxidant therapies should be done. Regular follow-up around every 3 to 6 months essential to monitor the progress of the lesion. Oral lichen planus. Lifestyle advice. Avoid hot and spicy food and have lichen-rich diet. Stress reduction. Advise yoga and meditation to the patient. Advise to use SLS, that is sodium lauryl sulfate, and paraben-free toothpaste, which are potent irritants to the oral mucosa. Topical anesthetic, which is a symptomatic relief to the patients, as given as benzocaine and lidocaine, choline salicylate, and benzylocaine chloride. Topical corticosteroids, which have anti-inflammatory effects, like the baseline is triamcinolone acetonide 0.1%. Comes in the form of Kenacort oral paste. Then clobetasol propionate 0.05% weight by weight can also be given. And tablet dexamethasone 4 mg swish and spit form can also be given. So we have to just mention that antifungals should always be given with the corticosteroid usage, because they have side effects of the fungal infection is the side effects of corticosteroids. So topical immunosuppressants like tacrolimus 0.1% weight by weight can also be applied to the affected area when corticosteroids are contraindicated, and in recalcitrant cases of OLP. Systemic corticosteroids can also be given depending upon the severity of the lesion. Other medications, azathioprine, cyclosporin, dapsone, hydroxychloroquine sulfate, levamisole, which is an anti-helminthic drug, are the newly prescribed medications. Low-level laser therapy and photodynamic therapy has also been successful results in oral lichen planus. Oral leukoplakia. Oral leukoplakia management contains antioxidants, which is effective in smokers, lycopene, which inhibits tumor proliferation, vitamin A, and retinoids, which are keratinolytic agents, to be given in oral leukoplakia patients in form of topical as well as systemic form. Vitamin C and E, topical bleomycin, which is a chemotherapeutic agent, photodynamic therapy, which is a non-invasive, good cosmetic results and safer for high-risk patients. Surgical management, cryosurgery, electrosurgery, laser excision can also be done in some cases. Oral submucous fibrosis. Apart from nutritional supplements and pharmacotherapeutic managements, we are giving oral physiotherapy in OSMF patients to gain more mouth opening. So exercises, mouth opening exercises using ice cream sticks and various devices to open the mouth can also be given in the form of tris care and jaw hole. They sustain pressure on the fibrotic bands, release trismus, and prevents further restriction of mouth movements. So these are the various devices which can be given to the patients. steroids, placentrix, and fibrolytic agents. So intralesional steroid injections can be given, and these are used in the form of these are used with insulin syringes, not the normal syringes, because these patients are more potent to have to have local traumas and pain. So insulin syringes should be given, which are blunt and short tip needles. So intralesional steroid injections, hyaluronidase, collagenase, placenterex, chymotrypsin, interferon gamma, and pentoxifylline in the form of tablets. Surgical management in advanced or severe cases, we prefer to give surgical management to those patients. Fibrotomy can be done in those cases, and laser treatment has also shown good results. Follow-up of all the OPMDs, depending upon the severity and risk of malignant transformation, follow-ups are performed at intervals of 2 weeks, 1 month, 3 months, 6 months, 1 year, till lifelong. So depending upon the clinical features, more than one lesions, more than one sites, high risk sites like floor of the mouth, lower border of the tongue, soft palate, non-homogeneous leukoplakia, erosive variety of OLP, burning sensation, coexistence of OSMF with other OPMDs, patient factors, high risk factors, patients are more than 50 years of age, female patients, with debilitating history, immunocompromised, and persistence or relapse of habits by the patient. Low risk category consists of small, homogeneous, no dysplasia with no high risk site. So we follow up interval is 6 to 12 months. For moderate risk, non-homogeneous mild to moderate dysplasia with burning sensation, every 3 to 6 months the patient has to be followed up. For high-risk patients, large multifocal lesions, severe dysplasia, ulceration, high-risk site, elderly patients and personal females should be followed with 1 to 3 months. Thank you.
So I want to thank Chief Ma'am for this opportunity to present our work on this platform, and Dr. Kani Gupta from Oral Medicine for supporting us. And I also want to acknowledge Division of Oral Medicine and Radiology, Division of Oral and Medical Surgery for providing us biopsy samples, Division of Public Health and Dentistry for supporting us in the public screening of the patient, Department of Preventive Oncology, AIIMS and NCHHL, Department of Otolaryngology, Veterinary Surgery, and IRCH, along with our partners from IIT and Bangalore. Thanks for your time. The floor is open for questions.
Thank you, Dr. Varun, Dr. Deepika, and Dr. Shalini. I must appreciate that it was a very short notice, and all three of you and the entire team have presented wonderfully your journey towards OPMD, and you have showcased the kind of research you have taken from 2015 onwards till date. So it is commendable. So a big round of applause for all of you. It shows a good teamwork, and I hope that in future also we'll be doing such wonderful job. So I must congratulate to the entire team. Thank you, and thank you everybody to be here and encouraging them during this journey. Thank you.
Yeah, any questions? Floor is open for discussion.
Anybody from there, if you have any questions on the site?
So thank you, everyone.
Like he mentioned the use of 5-amino hyaluronic acid for photodynamic therapy. So for some reasons, are you using it in your clinical practice? No, because I am interested because 5-amino is very expensive. Now we have the project we are getting it formulated in AIIMS itself. So if price is a concern for using this chemical, then we can probably expect some help there.
Actually, we aren't using 5 because the practicality of using it in dental is very difficult. We need dark room, we need the incubation time, which is in hours. So that's why we always wanted to use photodynamic therapy, but because of the cost restraints and of course the practicality of using it in the dental setting was always limiting us. So until we found some other sensitizers which are sensitive to other variants of light. So we are using those photosensitizers now for photodynamic therapy.
Any other question? So I just wanted to maybe request you just tell us what challenges you feel they face in routinely treating OPMD, especially over grade 3 and 4.
I just want to thank Dr. Indra for helping us out in all these situations regarding OPMDs. And we only get surgical cases, so doing surgery there is no difficulty. We just have to pat it out and ask them to help us out. But it has been a long journey and we have seen her working very hard and developing all these different platforms, starting from fluorescence and then coming to AI. Thanks a lot.
Any other questions? Any confusion when you see those OPMD cases and you face certain challenges in diagnosis or any other small queries? Yeah.
Okay, thank you everyone